Welcome to this BTOG podcast. My name is Newsom-Davis. I am a medical oncologist at Chelsea Westminster Hospital and vice chair of BTOG. This is part of our regular podcast series entitled BTOG Does, where we have informal chats with experts in their field and tackle the most important questions we all face in the diagnosis and treatment of thoracic cancer. It is important to say that the sponsors of BTOG do not have any role whatsoever in the planning, content, or delivery of anything that is discussed. Today's podcast is BTOG Does Lung Cancer Surgery, and we're actually recording this in a room behind BTOG Summer 2022, which has been held at the Hammersmith. And I'm delighted to be joined by my colleague, Ms. Sofina Begum, who is a consultant thoracic surgeon at the Royal Brompton Hospital. Sofina, welcome to our very exciting podcast.
Thank you for inviting me.
So we're going to talk about surgery in general. This is our first subject of surgery in our podcast series. So let's start at the very beginning. Tell me about what's the role of surgery in early stage non-small cell lung cancer, and what do we know about the benefits of it?
So early stage non-small cell lung cancer, from a surgical point of view, your aim would be to resect all of the disease with a R0 margin and stage the mediastinum.
Okay.
I think your resection needs to include both the lung and the lymph nodes, and I think if you don't take the lymph nodes, you haven't done a complete resection. I think that gives the patient the best chance of a cure. I think increasingly with evidence coming out, there may be other treatments may enhance the benefits from surgery, but I do think surgery is still the mainstay of treatment for those patients who are fit for it.
And one of the first things you said there was R0. So that means a complete resection. That means when the pathologist looks down the microscope, they cannot see any cancer around the edge of what you've cut. Why is R0 so important?
You want to make sure you haven't left any microscopic disease behind.
Okay.
If you haven't got that margin, the question will remain, have you left disease behind? Does that patient either need further surgery to complete their treatment or need consolidation with radiotherapy if they are not fit for a surgical procedure? If you had an R1 margin, for example, my first port of call would always be a further resection if the patient was fit for that procedure. If the patient is not fit for that procedure, then yes, I think a discussion regarding radiotherapy to consolidate your surgical resection is appropriate.
So R1 is microscopic, but when you were at surgery, you thought you got everything out. If you're in a situation where you've started the operation, you think, I'm not going to be able to get this out. This is going to be an R2 resection, so you can actually see there's cancer left over. Is that always an indication to stop? Do you then say, look, I can't do this, we're going to have to close, unfortunately, we have to think of other treatment options? Or are there situations where actually an R2 resection is an acceptable, albeit not an ideal situation?
Okay, so the first thing when I'm assessing a patient, if I think I am not going to be able to resect all of the tissue, is have I got enough tissue for other studies, for the moleculars, for the patient to have further treatment. Okay, so I will check that status first, and if there isn't, I will take more tissue at that point.
Okay.
The issue is, have they got a specific symptom related to their tumor that needs management? So, for example, I had a patient not long ago who had hemoptysis due to an endobronchial lower lobe tumor, but intraoperatively had upper lobe tumor LUTs.
Right.
Okay. In that patient, we'd already tried to control hemoptysis endobronchially, and that it was not an option. The disease was too far down. Patient did have a resection simply to allow them to continue their further treatment.
Gotcha.
Okay. But that's a very specific circumstance, and I think you need to be careful that you're not harming your patient. If you realize that actually you're not going to be able to resect all of the disease and this is going to be an R2 margin, you then need to think, how can I get this patient out of hospital as quickly as possible and get them to an oncologist? And 9 times out of 10, that means don't take any lung.
So R0 is our aim. You talked about lymph nodes. Systematic lymph node dissection, take out everything that you can see. You're taking out the hilar nodes or taking out the mediastinal nodes. Is there a minimum number of nodes that our colleagues should be looking at to say, I want to make sure these are taken out? Are there standards for this, or do you just take out what you can see?
No, absolutely, there are standards for this. So you want 3 lobe-specific N2 and then 3 lobe-specific N1 in your final pathological report. Now, that might mean surgically you take your 3 N2 stations and you take 2 N1 stations, and your pathologist gives you station 11, station 12. So the agreement we have at the Brompton is we'll take out the 3 N2, will take out station 11 and station 10, and then station 12 will be the pathologist's time out.
And so just remind people about the staging who aren't that familiar. N2 is mediastinal lymph nodes,
Yes.
N1 are hilar lymph nodes. And obviously what you're going to take out depends on which side the cancer's come and whether it's an upper, lower or middle node.
Yeah.
Okay. So we should be aiming for a minimum of 6 stations.
Yes.
And if you get more, then
that's a
much
bonus.
better. Okay.
I think if you see other lymph nodes that are enlarged intraoperatively, you're obliged to take them.
Yeah.
You should be taking them. You shouldn't be leaving those behind.
What about the difference? But we talked about the importance of R0 resection. What about the difference between a pneumonectomy, a lobectomy, segmentectomy, wedge resection? Lobectomy, in my inexpert opinion, is what tends to be done. When might one be using a wedge resection or segmentectomy instead of a lobectomy?
So I think we'll deal with the easy one first, wedge. So wedge resection really is not the procedure of choice.
Right.
This should only be done in a patient who is not fit for an anatomical lung resection. Okay.
Not fit because of lung function.
Yes, because of lung function. It doesn't permit you to do an anatomical resection, and it's not anatomically, it's placed in such a way that a segmental resection is not possible.
Okay, and just to clarify, a set wedge is you'll literally take out that little bit of lung, not based on any anatomical relationship, and then that's it. You're not taking lymph nodes, presumably?
No. Yes, you are.
You are, okay.
You are. There is nothing that, because there's nothing that precludes you taking lymph nodes.
Okay, because you're not removing more lung.
No.
You're just rummaging around the back.
No, so this is it. No, but this is it.
Yeah.
I think if you've done a wedge resection on the basis of the patient does not have enough lung function for an anatomical resection, you should still take the lymph nodes because you've done incomplete staging.
Yeah. Okay.
Because this is part of your surgical procedure.
Yeah. Okay, so wedge is only if you have to, and you go into it knowing that's what you're going to do because the lung is poor. Segmentectomy sounds like that's more anatomical, but you're still not taking a whole lobe. You're
not. So increasingly we're kind of going towards segmental resection, especially given the randomized control trial, phase 3 trial published April this year, Japanese study, 1,100 patients, randomized to lobectomy versus segmentectomy. As a non-inferiority trial. Segmentectomy for small peripheral, less than 2 centimeter lung cancers was found to be non-inferior and superior to lobectomy in terms of survival, and overall.
So less than 2 centimeters.
Less than 2 centimeter peripheral.
And regardless of lobe or side?
Regardless of lobe and side. It's interesting. It's very interesting data from our point of view. Obviously, with the advent of lung cancer screening, this is increasingly becoming our workload. And what we found is in the segmentectomy arm, yes, the air leak duration is longer, but that's a given. And
explain to me why that is, but because you're cutting into lung
rather than just dividing up fissures. But because you've preserved lung parenchyma, the lung function at 1 year is better.
Right. Interesting. Okay, so that's segmentectomy. Lobectomy is our standard.
Yes.
Pneumonectomy done much less. I mean, you don't have to be a surgeon to appreciate that if you're missing a lung, that's not good. Is it? Presumably a left pneumonectomy is less bad than a right pneumonectomy?
Yes. So for a left pneumonectomy, the mortality you would quote is 46%. For a right pneumonectomy, you'd quote 10%.
Well, so you're not doing that unless...
You want to be sure your patient is fit.
Right.
And with those patients, I mean, they need to have had lung functions, echocardiogram. You need to make sure there's no evidence of any right heart strain, raised PA pressures, because that's a whole procedure in itself.
And so you're only doing that because you have no other surgical alternative. Yes. And really, if it's going to be a pneumonectomy, presumably in that MDT discussion, should we say, are we sure we should be doing this? Yes. Is there not a chemo-rad option? Is there not a neoadjuvant treatment that might mitigate
I think
that?
If you're going to do a pneumonectomy, it's absolutely not, I wouldn't shy away from it in a patient who is fit for it. Okay.
Yeah, and we have a patient between us who's had pneumonectomy who's done brilliantly.
Yeah, absolutely. I think you shouldn't shy away from it if that is the patient's best treatment option. Okay. But what you should do is make sure you've completely staged that patient.
Got you.
Okay. And in those patients, for my threshold for doing a mediastinoscopy is very low.
Right. Because
I want to make sure they are truly lymph node negative.
So this is a mediastinoscopy you would do before the operation.
Yes.
To fully stage the mediastinum, even though they've had an EBUS, you're doing that, for example, because you want to make doubly sure.
Yes. That the lymph nodes were avid on the PET.
Yeah.
If they don't have any avid lymph node stations on the PET and they've had an EBUS, it's negative. I'm happy to take that. If the lymph node stations are avid on PET,
yes, then
even if the EBUS was negative, I would do a med.
Okay. So we touched upon about in that conversation about being fit for surgery.
Yes.
Respiratory function. We know everyone should have lung function tests before. We tend to focus on the FEV1. We tend to focus on the TLCO. But there's also mention in national guidelines and local guidelines about CPEX testing. Yes. Sometimes people do that formally. Sometimes people walk some up and down the stairs. When do you do formal testing? Should everyone have it? And what are the situations where you say this surgery is not going to be possible because of cardiac or respiratory function?
So with a lobectomy, if I'm considering anything other than a pneumonectomy, I will tend to walk them up and down the stairs, or I will tend to shuttle walk them. Okay, with a pulse oximeter.
And shuttle walk is how far?
25 meters.
Okay.
25 meters, 25 meter shuttles, and they have to get to 140 at least.
Meters in total?
In 6 minutes.
And you're watching just that they can do it, or do you look at the drop in sats? Or
so I'll measure sats and heart rate.
Okay.
And I'll look at how many times they've stopped.
Okay.
And I'll look at what their recovery time is and what they desaturated to.
And is that as good as other forms of cardiopulmonary? I can't say it.
Formal cardiopulmonary exercise testing.
And shuttle test, is that as good? Or
those numbers in view of the lungs I'm seeing on the CT scan and the target lobe. So I'm looking at, so we also do lung volume reduction surgery. So if I'm looking at a patient and they've got, for example, heterogeneous emphysema, upper lobe LVRS target, and they've got an upper lobe cancer, the numbers I'm looking at and accepting are very different to what I would accept in somebody with kind of no emphysema. So for example, if an FEV1 of 21% wouldn't worry me in somebody who had emphysema, because I'm going to take out their emphysematous lung, and actually they should be less short of breath after my procedure because I've done LVRS.
So the message, I guess, to our audience is, yes, always look at lung function, but taking context of the patient and what's going on and what you're proposing.
Yes.
Okay.
So how much lung function are they going to lose? What's their IV? Are you going to give them a lung volume reduction effect? If you are, carry on.
Okay. Next question, lots of questions. When do we need a biopsy before surgery? Can be very difficult. I appreciate ideally everyone would have a biopsy, but it's not always possible. What's your view?
Absolutely need a biopsy before pneumonectomy.
Yeah. For
sure.
Okay.
Because the risk is so high. Before a lobectomy, if it's a peripheral lesion that I can wedge easily and do a frozen section on, before I continue with my anatomical resection, I don't need histology.
Okay.
That's not going to add much to my procedure. I'm going to be dissecting out the hilum while I wait for my frozen section result. So that's not a problem.
And just to explain to people, frozen section is you're in there, you've opened the chest, he said in his great surgical knowledge, then you are taking a sample which is frozen on site. Pathologist then comes to you and has a quick look and says to you, cancer or not cancer.
Yes.
We don't have any immunos, but at least you know.
Yeah.
And then if it is cancer, then you have the go ahead, so to speak, to then complete your lobectomy or
Yes.
whatever you might be doing. Okay, so we've talked a lot about non-small cell lung cancer. What about small cell lung cancer? Now, obviously, most people I see with small cell lung cancer have metastatic disease because it's a very aggressive tumor, but people do have early stage small cell. Is there a role for surgery? What evidence do we have? When can we and when shouldn't we be doing surgery?
Okay, so the evidence we have isn't randomized control data at all. It's the best data we have is from the SEER database, SEER analysis. Okay. So they looked at 14,000 plus patients with small cell lung cancer, and they looked at survival for early stage, early patients who had had surgery and those who hadn't had surgery. And at 5 years, surgery, patients who'd undergone surgery and chemotherapy versus those patients who'd had no surgery for early stage. So this is the T1, T1, T2, N0 cohort.
No nodal involvement,
no
small
nodal
tumors.
Involvement. These patients had a 50% 5-year survival versus 5% in those who had no surgery, just had chemotherapy.
So that's a no-brainer.
Yes.
That is if you have an early stage small cancer, you haven't got it, node negative, phone your surgeon.
But the other thing this analysis looked at was upstaging. Okay. And they found that 20% of these patients had upstaging of their clinical stage, pathologically. Yeah. Okay. So what I would say that if you're contemplating surgical intervention for patients with early stage small cell lung cancer, you must invasively stage the mediastinum.
Yeah, absolutely.
So that's an EBUS or a MED, depending on what your preference is.
And from a med-onc point of view, I would also say to people that if you do happen to have done surgery, adjuvant chemotherapy is going to be needed. Not as much evidence as there is in non-small cell, but this is an aggressive tumor.
Yes, and I think these are patients that you should see together in clinic. Yep. If you're contemplating surgical resection, and you must make sure that your oncology colleague is absolutely happy to give chemotherapy to that patient.
That's a very good point.
And because if there is for whatever reason, this patient is not able to have chemotherapy, do not intervene surgically. There's just...
So back, I guess, more to non-small cell lung cancer. My colleagues in clinical oncology have lots of fancy toys. They have stereotactic radiotherapy, they have SABEV, all sorts of things with names like Gamma Knife and Cyber Knife. Not real knives, but that's what they think they are. Are you going to be usurped by these guys? Where does stereotactic radiotherapy have a role where surgery doesn't? Where would you see that?
I don't see it as a competition.
No.
There are certain patients for whom surgery is appropriate, certain patients for whom stereotactic radiotherapy is appropriate, and certain patients actually either is appropriate. It depends on what the patient would like. I think there are certain patients with fibrosis for whom a radiotherapy option is unrealistic.
Yes.
Okay. And those patients wouldn't be my clinical radiology colleagues would not be happy to see those patients. Whereas there are also similarly, there are patients who we are not happy to operate on, especially if they've got an FEV1, which is less than 20%. And or a patient who's got emphysema and the tumor is in your non-target lobe. That doesn't help you. You're not going to want to remove healthy lung.
Yeah. Okay. So it's very much working together to identify those patients where stereotactic radiotherapy is going to be an option when surgery wasn't possible.
Yes.
Yeah. Okay. So last thing I want to go on to is about you. So tell me how you ended up, your consultant at Brompton, Royal Brompton, very impressive. How did you end up in your career path? What led you to the doors of Brompton?
So I graduated from Leicester. 2004. Then I went on to complete my foundation training in Birmingham, and I kind of decided already that I was going to pursue a career in surgery. Hadn't decided quite what type of surgery, but I really enjoyed vascular surgery at the time. And so I'd applied for a basic surgical training rotation in those days. Shows you how old I am. And it was about a year through that when the Modernising Medical Careers came in, and that just kind of changed careers a bit. I applied for core surgical training in Leicester, and the plan was I would be doing a year of whatever I was given, and then a year of vascular. And actually I did 6 months of cardiac surgery, and I did 6 months of thoracic surgery.
Right.
And I really enjoyed that. That 6 months of thoracic surgery just completely changed.
And you're suggesting in that, and as conversation we had a little bit before we started recording, that there's been a change in thoracic surgery, because in the old days, so to speak, you'd be a cardiothoracic surgeon. Well, in the very old days, you'd just be a surgeon. Then you were cardiothoracic, but now there is a dedicated specialty, which is thoracic surgery.
Yes, and in those days, thoracic surgery was, as a specialty, was very much in its infancy.
Right.
This whole idea of being a pure thoracic surgeon, the majority of the units in the UK at that point did not have a pure thoracic surgeon in place. And this has only been, I think it's the last 5-10 years that's changed. That situation has changed, where units have had to appoint thoracic specific surgeons. And now if you're appointed as a consultant cardiothoracic surgeon, you will either be cardiac or thoracic. To the point that even in training, they will have to declare, trainees will have to declare either cardiac or thoracic fairly early on, and then their training will be kind of guided by their chosen specialty.
Can't help noticing you're a woman.
Yes.
I'm lucky enough to work in both my MDTs. Both of our thoracic surgeons are women, which I think is fabulous. But you are in a minority still in thoracic surgery. What was that like going through training, and how do you see the future of women in thoracic surgery? I mean, clearly the future must be bright, because the numbers are increasing and things are changing hugely. When
I was first appointed as a NTN, there were very few female cardiothoracic.
Because people put off, because it wasn't.
Yes, because at that point the specialty wasn't separated, and I'll be honest with you, I really didn't enjoy cardiac surgery. This was not a specialty I wanted to do at all. I found the physiology interesting. I found the anatomy interesting. I didn't find the operating interesting. Whereas with thoracic surgery, I found all of it interesting. And the whole approach appeals to me. Whereas I don't think prior to doing that 6 month in thoracic surgery, I'd even considered this as a specialty, because it simply wasn't a specialty in those days. And I think people are now increasing awareness of this as a specialty, and people are seeing role models and they're wanting to come along, spend time. I'd also recommend that if you're going to do thoracic surgery, if you're appointed to an NTN number, go and speak to your TPD beforehand. Okay. Plan your time in training. Because what you want is, you want to come out of training as a competitive surgeon. You do not want to be somebody who's just about struggling to do the basics. So you want to come out with good numbers. You want to come out being able. So in my day, when you were training, that's procedures were just kind of on the up. And if you had exited training at that point and were able to do an open resection but weren't able to do a VATS resection, you would have just about been okay.
Right.
Okay. But in this day and age, you would not be okay. You would have to have significant procedure numbers in terms of minimally invasive procedures. And I think you'd need, when I first started training, I went to see my TPD and I was like, right, I'm going to do the bare minimum cardiac surgery, and then I would like to spend my time like this, please. And I knew that being able to do a VATS procedure was going to make me very competitive. So I wanted to make sure that the number of procedures I'd done VATS and open were about the same. And I was in a very fortunate position that actually I was able to pick that up in my within my training program, rather than having to go out of program to achieve this. And at the time, there were a lot of VATS fellowships, and you could have gone out of deanery, done one of these programs, and you probably would have picked up 30, 40 resections in that year. At the time, I discussed it with my TPD, and that didn't make sense because I was doing 100 plus resections per year.
So be a competitive surgeon. I like the idea of a non-competitive surgeon. I've never met one.
No,
but, you know.
so this is, I mean, it's, you want to be sure that when a unit is considering appointing you, you have the skill set they are looking for. But also, I think in thoracic surgery, you really do need to get on with your MDT.
I agree.
If you're thinking you're just going to sit there and decide what treatment's going to be, that's just unrealistic.
Absolutely. And I think the thing I've learned, just to wrap up, I think the thing I've learned is that when it comes to surgery, in fact, all of thoracic oncology, it is very much MDT, and no one works alone.
No.
So that brings us to the end. Sofina, thank you very much for joining us. I've learned, as ever, a huge amount. Thank you to the audience for listening. You can hear more podcasts on the site where you download them from. We are making changes to podcasts in the next month or two with two presenters in the future. Dr. Leanne Castle is going to be joining me. She's a consultant respiratory physician extraordinaire. So keep tuned, and thank you for joining us today.